Everybody ready? Okay, so at this point we're going to regroup and think about what other diagnoses, again, we may see the other comorbid conditions associated with autism. We have already gone over this once, and actually that really nice Venn diagram I made mention, I found to somebody who asked about it, I Googled it under comorbid plus ASD, and boom, I found it on Google Images. So I'm not going to talk through this slide, but I kind of wanted to reorient us because we're going to talk about some of these comorbidities. Kids, when they come to our clinics or to your primary care practices, if they have autism, these visits can be so incredibly overwhelming. So I just wanted you to think a little bit about what your clinic setting looks like in welcoming these children into your practice. I always ask what works best for the child, and I take my cues from the family. And we do pediatrics. We're flexible. If you are running late and you walk past the room that the child is in, you will often hear screaming. That is a child who has been waiting for too long. So avoiding keeping those children waiting can be really helpful. We can also set the tone terribly if we pull out a NAPNAP and decide we're going to get one of those electronic blood pressures on an already very anxious child at the beginning. You can really set a tone for a bad visit if the child has bad experiences. Another thing, just think about some of the sensory things. Some kids hate sitting on the paper on your exam table. That crinkle makes them crazy. Other times they think it's fun to shred and eat. I will often do an exam on the floor, meet the child where they are, do it on the parent lap, use the toys and do my practicing on those, and then let's try it on you too. We like for the kids to bring their favorite books and toys. The one caveat to this is when you're doing the ADOS, because you don't want them to bring their favorite toy to an ADOS because you don't want to have to take it away because you need them to play with what's in your bucket. And then always providing lots of encouragement and rewards. This is stuff we all know. The next thing we're going to talk about is our friend Katie, now that she's in preschool. So she has her 3-year well child check. The parents have talked to their pediatrician about this evaluation they had in the autism diagnosis. They have early intervention providing ABA therapy now. She's getting her school-based services at age 3 through whether it's the intermediate unit or Head Start. And then she's enrolled in a nice specialized program that includes speech, OT, and some behavioral therapy. But the family is really struggling with her behaviors now. Those tantrums are huge, especially with transitions, and this girl won't toilet train. So she's getting the ABA therapy in the school setting, but the parents are still struggling. So now we want to involve services in the home setting if they're not already done. And you might want to write a prescription that can be used with Katie's medical insurance. Couple quick things. Many children will automatically qualify for a state-funded or a medical assistance insurance because of this diagnosis, which is really helpful because they can cover co-pays for, therapies and all of these other services. The other thing, we've had a number of questions come up about can nurse practitioners make a diagnosis that is accepted so that services can be provided? And I think that this is going to take some ongoing advocacy because we are hearing that in some states the nurse practitioners are being told that it has to be a psychologist or a psychiatrist or a developmental behavioral pediatrician or sometimes more than one person. But as nurse practitioners, they're not accepting our diagnosis. I think this is going to be a great talk for the SIG meeting tomorrow. And I would like to see some joint advocacy between SDBP and NAPNAP regarding this to put out some support. So this is going to be a work in progress. We'll go back really quickly and talk to Katie. Mom's now worried about this very limited diet for her and says that it can take hours for her daughter to fall asleep at night. We already talked about how she wanted to, parents had to fall asleep with her, and then in the middle of the night she went back seeking them. So I'm going to give you some of my clinical pearls for eating problems. I used to work on a functional feeding team with occupational therapy, speech therapy, behavioral, nutrition, etc. With our kids with autism, a lot of times parents will describe what we lovingly call the beige diet. It's going to be pancakes and waffles and cereal and French fries and crackers and chicken nuggets. So what I like to do, if it's something that's available in your area, is refer them for an interdisciplinary feeding evaluation. Having that meeting of the minds, talking about where the child's eating problems are, what the preferreds, the non-preferreds are, what the behaviors look like, how much is their calorie intake, what are the behaviors around the mealtime, can really provide some solid suggestions for the family. Another thing that's really, really helpful for families is involving the child in food selection and in food preparation. Give them a little investment in the food that's going onto the table. And I like to introduce very tiny variations on preferred foods. If they like applesauce, so maybe we try some pear sauce, or maybe we try a berry flavored sauce. One of the things I used to recommend to families was a color of the day food. And today we try one green thing, and we're learning our colors, and we're trying one green thing. We can have blue day with blueberries or a touch of blue food coloring if it's a child who can tolerate food dyes, maybe in their applesauce or in something. And then the big thing is expanding their tolerance, and you're going to progress them. First, they're going to just smell it. I know we're just going to smell it today. Big praise on that. Next day, just kiss the food. Just let it touch your lips. You do not have to taste it. But tomorrow, maybe we'll do a little lick. Then they can hold it in their mouth and then spit it out, and then move to taking a bite. A mom of one of my children, one of my patients who has autism, has always referred to it as the no thank you bite. You cannot say no thank you until you've tried one bite. And parents love being able to feel like they have a little bit of power. It's a no thank you bite. You can say no after this. But these are some of my pearls for dealing with feeding problems. Sleep issues are huge in children with autism. So that delayed sleep onset, that night waking, that just disruptions in their sleep overall. Really, behavioral interventions can be huge. Really working on sleep hygiene, which we'll talk about. And then there can be possibly a role for medication or a natural supplement that we'll get into. This is also a really nice just pictogram of what bedtime can look like, and this can be up for the child to help them remember that schedule. Toilet, teeth, pajamas, book, maybe a drink unless they're bedwetters, and then going into their bed and moving into sleep. Clinical pearls for good sleep hygiene. One is obviously keeping that bedtime as regular as you can. Can be really challenging when kids live between more than one place, or mom works evening shift and picks the child up from the babysitter. And you want to have a really relaxing routine leading up to bedtime. You want to have a bedroom that is conducive to sleep, and I really love the term nocturnal oasis. There might be very soft music, there might be a nightlight, you might have a little weighted blanket for the child to help them just feel grounded into bed. We need them to learn to soothe themselves to sleep in their own beds. So you want to have the conditions that would be available all night long for them. In the middle of the night, if that parent doesn't want to sleep in that room every night until the child's well into adulthood, that child needs to fall asleep in their own bed under just conditions where when they wake up in the middle of the night and they look around and go, oh, I'm fine, and then they go back to sleep. We want to establish a goal of eventually having them fall asleep alone. If you tell them that on day one, it's never going to happen because you haven't taught the child any skills and you haven't worked with the family to put any other supports into place. And then I will still refer kids for sleep clinic evaluations. At my clinic at Children's Hospital of Pittsburgh, we have a behavioral sleep psychologist who works with kids just on skills to help them learn to fall asleep, taking a good sleep history and hearing while they're daytime mouth breathers and they snore loudly at night and they're Send them to ENT. They sound like that. Send them to ENT and at least get the whole thing evaluated. Some of the behavioral sleep interventions, our goal is to reset the bedtime, not having them up until 1 in the morning. You're going to fade their bedtime. You start moving it back by 15 or 30 minutes a night. Another thing is stimulus fading. If that child was only falling asleep when that parent was next to them, the parent is sitting in a chair. The parent is sitting further away. The parent is out in the hallway. We're in for the long haul, so they've got to be willing to make the changes now because this is an investment. And then also, this one I feel a little more controversial about, but the idea of scheduled awakening is where the caregiver may slightly rouse the child before that child would typically spontaneously wake up during the night, just enough that they kind of come up and then go back down on their own, because once they come up on their own, they're not going back to sleep. Another possibility is using a picture of a clock, which I realize is a lot harder nowadays that everything's digital, but you can't come out of the room until you see these numbers on the clock. And my favorite are the clocks that you can now buy for children's rooms, where the light will turn green when the child is allowed to come up and get out of their bed. They can do a lot in their rooms in the dark or in the middle of the night or early in the morning, though. And it's very important, safety is first. I have parents who are very, they still use room monitors for the child, and they use little bells and things like that so that they hear a noise that lets them know that the child is up in the middle of the night, because we want to make sure they're not, trying to leave the house, etc., in the middle of the night. To briefly mention sleep medications, basically our whole idea is just promoting drowsiness and shortening sleep onset. The half-life of melatonin really, and most recent thing I read was like 30 to 50 minutes. So this is not even a supplement that is meant to put you down for long and keep you down. It just meant to help your body go, hey, it's time to wind down at night. So you can get the sleep onset improved. If we can move to kids that are doing who can swallow an extended release, that can give them that second boost to keep them down a little bit longer. And dosing might be anywhere from even 0.5 milligrams. I know I have 1 milligram up here, but sometimes you don't want to use any more than the kids need. So sometimes even 0.5 milligram is enough to get kids down. Usually around 6 milligrams. If it's not working, it probably wasn't gonna, but I definitely have seen pushing up to 10 milligrams. Who in here uses some melatonin? Yeah. Okay. And then we're going to talk about toilet training very quickly too. Our number one goal for the toilet training is treating constipation. You want to do this in a very nice stepwise approach. You can use visual aids for this. I like these little diagrams here that tell them exactly what they're supposed to do once they sit on the toilet. The wiping is definitely a challenge for a lot of kids. Pulling up their pants, washing their hands. There's another whole pictorial for exactly what hand washing would involve. I love the commercials for the squatty potty, but this makes really good sense. A child who's trying to sit on the toilet with their legs dangling cannot really build on that intra-abdominal pressure to bear down to poop. So sometimes something as simple as that. And another one of my favorites is not asking your child if they need to go to the bathroom, telling them that they need to go to the bathroom. There are a couple books that can be ordered online that are specific to potty training in kids with autism and developmental disabilities. There's one that's called Ready, Set, Potty, and it's by Brenda Batts. Autism Speaks also has some really nice information on their website, and the AAP Autism Toolkit also has some nice information on toilet training. So I know I pull those handouts, and I give those handouts to parents regularly. I'm going to switch back over.
Okay, we're following Katie longitudinally over time. Katie is now 9 years old, so we get to see how she's doing. She's continued to make progress. She was placed in a regular classroom for kindergarten. She did well. She's currently in the 3rd grade, and she came back to developmental behavioral pediatrics because she's having frequent outbursts at school. She's yelling, she's swiping materials off the desk, she's attempting to elope and leave the classroom. To avoid disruptions to the rest of the class, Katie's sent to the principal's office when she's yelling, and there she hangs out and talks about her favorite Disney princesses with the office staff. A teacher says she's active and not paying attention well. So first, what is the reason for her outbursts? The caregivers come in and they ask you, they want an answer. Is this because of her communication difficulties? Is this because she has intellectual disability, anxiety, ADHD? Do we need more information? So use your clickers. Yes. The answer is likely multifactorial, but at this point we need more information. We don't know what's going on. And the school needed more information, so they requested an updated psychoeducational evaluation. So more psychological testing was completed at school. She was administered the WISC-5, and here are her scores. You can see that she had a relative weakness in verbal comprehension reasoning abilities, which were in the extremely low range. Visual spatial reasoning abilities were significantly higher. It was an 80, which there are different interpretations. I would say low average. Fluid reasoning is borderline. Working memory was a relative weakness in the extremely low range. Processing speed was another strength and in the low average range. Her full scale IQ was in the borderline range, but you can't interpret the full scale IQ because there's such discrepancy among the composite scores that are combined to generate that score. The school also obtained measures of adaptive functioning. She was administered the Vineland-3. Communication is a weakness. Daily living skills and social skills are in the borderline range. Motor skills are a strength. We also collected behavior rating forms. Parent-teacher BASC-3 forms showed elevations, again in atypicality, withdrawal, inattention, and now some anxiety. So how would you interpret this? Katie's intellectual functioning falls within what range? Within normal limits, borderline, mild intellectual disability, moderate intellectual disability, consistent with autism spectrum disorder. Use your clickers. Okay, so the majority of people said borderline. Some people said consistent with autism spectrum disorder, and there was a range of responses. I would agree with the borderline answer. Her scores are below other children her age. I would not give a diagnosis of intellectual disability with enough of those scores in the 80s, but she likely needs additional supports and accommodations to address her cognitive difficulties. And intellectual functioning, there's a range of intellectual functioning among people with autism spectrum disorder.
So we'll do some really quick updated diagnostic impressions. So she's back in our clinic. Her history and physical do not reveal any new additional information on why she would be having behavioral changes. She's healthy, and now she's eating and sleeping well. No changes at school. The school evaluation supports the following formulation for autism spectrum with borderline intellectual functioning, with accompanying language impairment, and with anxiety. Our next steps are going to be to try to understand why Katie is behaving the way that she is and provide additional treatment for that. So what we're going to order is a functional behavioral assessment. A functional behavioral assessment, or FBA, looks at the reasons behind that child's behavioral problems. We want to define what the inappropriate behavior is. We want to collect the ABCs, the antecedents, the behaviors, and the consequences. Come up with what our hypothesis is, reasons for those behaviors, and come up with a plan. So antecedents are going to be what comes directly before the behavior. What is our trigger? B is what does the behavior look like? And C is for consequences is what comes directly after the behavior. What does the child think they're getting out of that behavior? And what actually does then happen? So we're going to do a real quick functional behavioral assessment for swiping, just pushing things off the table. And what we figured out is her triggers, her antecedents, are when the teacher gives multi-step directions, or there's a rise in the background noise level, or she's asked to do something she doesn't want to do, like a more complex academic task. Her swiping consists of pushing materials off of the desk and throwing things. And then the consequences include being told to stop, giving a thoughtful explanation of why she shouldn't do it, or just, take her out of the classroom and send her to the principal's office, okay? So what in the behavior analysis, what we see is that this is a response to things that overwhelm her. Too much language, complex directions, too much commotion. And what she's trying to do is escape or delay complying with the directives that have been posed. So our treatment recommendations that come out of this FBA, either we're going to ignore or redirect, or we're going to praise her engagement in any alternative behaviors unless she's in danger of hurting herself or others. We want to provide appropriate ways where when she feels overwhelmed, she can ask for a break. Do not allow her to avoid the behavior or avoid what she's trying to get away with. Sending her to the principal's office is exactly what she wants. It gets her out of where she doesn't want to be. And then understanding some of her triggers and modifying her environment or planning for it are critical. So I'm not going to read over these. This is a kind of like a nice stepwise approach to behavioral problems, making sure the child's safe, considering all the potential triggers, thinking about using medication if needed, individualizing her treatment plan, and a safety plan is needed, and then deciding, where are we? Do we need to continue? Do we need to do something differently? So reevaluating every 3 months or so.
All right. I wanted to talk about a few conditions that often underlie some of the more disruptive behavioral presentations we can see in kids who have autism spectrum disorder. They are often seen more frequently in individuals who have lower language and intellectual skills, but that I've also had patients who are very high functioning cognitively who have really significant behavioral outbursts. Anxiety is one of the primary underlying causes for disruptive behavior. So anxiety can be increased for any individual, and particularly for kids with autism, when they're having challenges communicating, when they're not understanding what's expected or they can't tell people what they need. Because they have trouble reading social cues, they're often very uncertain in social situations, and they don't know what's going to happen next, and that can increase their anxiety. And so kids who are anxious may present with tantrums and outbursts because they're not very flexible and they don't have good coping skills. They can also look irritable. They can engage in aggression or self-injury. And they may have trouble sleeping because of their anxiety, or they may be having sleeping problems that are making them less able to cope with anxiety. So the whole talk about sleep management is really critical for our patients. The management includes making accommodations, using cognitive behavioral therapy. This is now evidence-based for kids with autism and can be implemented. Hello? Hello? We don't have sound yet. Yeah. Oh, we're back. Don't know where I was. Oh, and cognitive behavioral therapy, yes, can be used for kids even with developmental functioning as young as 4 to 5 years. And it has been adapted for use with kids who have autism. And so some of the accommodations we've talked about already, like the visual supports, previewing what's going to happen next, what's expected, using social scripts to kind of model how a child should behave in a situation. Self-injurious behavior occurs frequently in individuals with reduced communication skills. It may be a way of expressing, so it may be have a communicative function. Alternatively, sometimes it has a sensory seeking function. And so FBA is very important because you're going to respond differently depending on what the function is. You always want to ensure safety. And if it's a new behavior, you always have to go back and do a medical evaluation. Could there be any physical condition, pain, other situation that is triggering the child to engage in that behavior? And the most common ones we've listed are headache, dental pain, and then GI discomfort, either due to reflux or constipation. And really treating these conditions can significantly reduce behaviors in a child with autism. They're not able to tell us what they're feeling. This slide just lists some additional safety concerns. We've mentioned pica several times this morning about screening for lead poisoning, but some kids really engage in odd behaviors that can have health consequences. I had a patient who presented with bowel obstruction because he had been eating rubber bands, and we only found it on his x-ray, and the school was able to do a whole fantastic behavioral program that taught him he can't eat those things and he has to ask for a snack. And he would come into the office and look and say, no, eat rubber band, eat chips. Wandering is also a significant concern, and there's a lot of advocacy nationally now related to this, and so we just wanted to alert you to some guidelines on the Autism Speaks website and some safety measures families can implement in their homes.
Couple quick words on sensory processing issues, which we see are a really huge issue in our kids with autism. They really have a hard time regulating the degree and the intensity and the nature of their responses to sensory input. Some kids are very sensory seeking, some kids are very sensory avoidant, and some kids are a combination of the two. So again, we want to refer out to occupational therapy. I've kind of already mentioned their role in this. This is a little bit of a mention of different types of sensory profiles. It's not common to see a kid who has a perfectly balanced sensory profile if they're on the autism spectrum. Some of them show a lot of high avoidance. Other kids can show a lot of increased sensory seeking behaviors. And I make a mention here of once they're in occupational therapy, there are a lot of different things they can do. They can have some passive things to help them, wearing a weighted vest, doing joint compression and things like that to give nice input, or they can have activities like jumping and rolling on one of the therapy beans or balls. Families learning a lot about sensory can help them, and I have some nice resources I can share with you later if you want them. And the other piece would be doing a sensory diet where you're designing physical activities and accommodations that provide a balance of preferred and less preferred. It's like our diet, we got to eat our vegetables and all that. You want to have a balance of things in there. The issue with OT is that there's not a lot of great data out there that supports this must be done, but we find very much that families and children can make a lot of behavioral gains just by doing these.
All right, so returning to Katie. So her school team revised her IEP to include more special education support in a smaller and more specialized classroom that had less sensory overload, less language overload, and included a positive behavioral plan. And they were using some of the strategies we talked about to help her with the transitions throughout the day and to be able to ask for a break if she was getting overwhelmed. Now, there were concerns about her hyperactivity, which you'll remember back to the initial presentation at age 2. And a trial of extended-release methylphenidate resulted in reduced appetite and agitation and crying. Guanfacine was tried next, and that actually helped with the hyperactivity, but unfortunately she was too sedated and sleepy. So her parents, remember back to the recommendation to add in some more supports at home, were able to access home ABA and implement similar strategies. And with the recognition that anxiety might be a real trigger for some of her behavioral issues, she was started on a low dose of sertraline, 12.5 milligrams, and this, in conjunction with the behavioral supports at school and home, seemed to help with the anxiety, and she had fewer tantrums and was better able to tolerate transitions. Now, we're going to talk briefly about psychopharmacology, and we're happy to answer questions at the end of the talk. But I just want to start with a caveat that we really have very little evidence to guide our practice, and that's why I had the disclosure for this talk about a lot of our medication use is off-label. So a lot of times we're extrapolating data from studies with typically developing or neurotypical patient populations and applying those to kids with autism. And sometimes we find that the same medications work well, and sometimes they may not work quite as well. But about 45% of kids with autism are treated with psychoactive medications. Why do we have such a limited evidence base? Well, first of all, it's hard to get any trials funded for pediatric studies. But it's also very difficult to define what target we're treating. So a lot of times, they'll use measures such as the aberrant behavior checklist and look at irritability, but that includes symptoms related to aggression, to self-injury, to tantruming. They may not all be the same thing. It's difficult to discriminate sometimes anxiety from irritability or anxiety from stereotyped behaviors. And they aren't the same thing, and they don't respond to medication the same way. There are no measures to target mood symptoms for individuals with autism. And then I think the other thing that's been really challenging with research studies is that it's such a heterogeneous population that the study may conclude that there was no difference in the treatment versus the non-treatment group, but there may have been subpopulations within that treatment group who did really well, and the data gets kind of lost. So we need to analyze data better. High placebo response also makes things challenging. So we're going to talk a little bit about some general principles of medication management in patients with autism. Remember that they tend to be more sensitive to medications. They may have higher rates of side effects. So you want to start low and go slow. Start at lower doses and go up more slowly. Try to figure out what the target symptom is. I'll just tell you that almost every family I see who has kids with lower verbal and intellectual skills are worried about hyperactivity, impulsivity, anxiety, and aggression, and they don't know which one is which, and it's really hard to pick which to treat, and everybody's nodding, so I guess I'm not alone in this. It's also harder to monitor side effects if the child isn't able to report verbally. And the only FDA-approved medications for irritability are aripiprazole and risperidone. We don't have any other approvals or other medications that are on label. Some of the target symptoms that we can address, though, using medications that have been assessed in typically developing populations are symptoms of ADHD, hyperactivity, inattention, impulsivity, irritability and agitation, repetitive behaviors or thoughts, and anxiety. There are no medications that work great for stereotypy other than atypical antipsychotics. So if it's a repetitive behavior and you're thinking of an SSRI, you really need to decide, is this an OCD anxiety repetitive behavior or a stereotypy? And then also sleep was mentioned earlier. And this slide just summarizes the evidence base. It's from a nice study that looked at a systematic review, and we don't have a lot of new data to add, even though this was published in 2012. But it does show that there's some evidence that alpha agonists can be used to target hyperactivity and sleep, stimulants and atomoxetine for ADHD symptoms. We've already talked about the atypical antipsychotics, predominantly to be used for irritability and aggression, but they can help in some patients with stereotypy and anxiety. SSRIs primarily for anxiety, and melatonin for sleep. And I sometimes use alpha agonists for anxiety as well. So when I get those families where they can't figure out what symptoms, sometimes clonidine is a good starting point. Just some cautions about using antipsychotics. I'm sure everyone's aware that they have higher rates of side effects that can really have significant medical sequelae. So we want to monitor closely, and we recommend lab testing about every 6 months to look at blood count, to look for lower white count or platelets, liver function and cholesterol, and then some marker of diabetes, either fasting glucose or hemoglobin A1C. And in sometimes these medications can elevate prolactin. It's not a reason to stop medication unless it's really high, like levels of 100 to 200, or it's causing symptoms like galactorrhea. EKG, some people recommend getting it for all patients. It's conduction problems are seen most frequently with Geodon, not as much with Abilify and Risperidone, but I do think it's good to get baseline, and if you're doing a big dosage increase, consider that. Remember that these medicines affect dopamine and serotonin, so when you're combining them with SSRIs, you just need to be a little cautious. Has anyone had patients ask about marijuana and wanting to use marijuana? So there's really very limited evidence to guide us, and the legal landscape is constantly evolving, and the federal law and state laws often conflict, and so you're in a tough situation. This slide just summarizes the evidence that's available right now. There is a study going on in Israel, but we don't have the results yet. So CBD, or cannabidiol, is non-psychoactive, and it is actually authorized for treatment of Dravet syndrome, which is a very severe seizure disorder. And there was one case study that showed improvements in one individual with autism. So that's very limited evidence to guide us. Dronabinol is a synthetic THC and is the psychoactive component. And there was an open label trial, just one open label trial, that showed improvements in some of the participants, but 2 of them withdrew due to agitation. So I think it's helpful to share that with families. So we have a quiz for you. Katie's parents ask your opinion on complementary alternative medications and approaches, and they mention diet and want to know if you suggest any other non-medicine treatments. So which is true? There were a few adverse effects with supplements. CAM is supported by multiple randomized controlled trials. Gluten-free, casein-free diets benefit patients with autism who don't have celiac disease, and stem cell transplant is a promising treatment, or none of the above. Put in your answers. All right. Very good. So there are adverse effects with a number of different diet supplements and other treatments, and we have another slide that has some of that data that I'll show you in a minute. There are randomized controlled trials for a very few kinds of alternative treatments. A lot of them aren't as well studied, and gluten-free, casein-free diet showed benefits in patients who had sensitivities and symptoms of, intolerance, but not in a generic patient who didn't have that. Why are we talking about CAM? Well, families who have kids with autism use CAM a lot. Up to 70% will try different kinds of treatments. It's advertised a lot online. There's a lot of information that they may be getting from family and friends. And oftentimes they're frustrated with the lack of efficacy we can provide with what we're able to offer. There are often placebo responses, so people try something and think it's better because they're so hopeful that it will be better. But there can be a number of adverse effects: hypersensitivity, toxicity to high doses of vitamins, potentially interactions with prescription meds, and then also other factors such as not spending your time or energy on validated treatments, and so that can be a problem for some families. But it's important to really understand what is the family looking for and what's driving them to seek these treatments, so that you can have an open conversation and make it safe for them to tell you what they're doing, so you can share any evidence that you do have about potential benefits or adversities. And we've listed a couple of websites that have nice discussions of different kinds of treatments that you can look at if families have a question. We're not going to go through this slide in detail, but we're happy to take questions. But it just groups therapies by the level of benefit and the potential level of risk that's been documented in any kind of studies. And at the very end, we have things that haven't been well studied. So we don't have as much to recommend in that area.
So in an attempt to kind of round this all up and clean it all up, I want to first talk about the family support needs. And a really good family support can really help, make or break this experience that the child and the family helps. They need individualized treatment. They need individualized support. They need to be a partner in all of this. So I pull back to shared decision making. This is obviously an interdisciplinary model for working with children. We've talked about so many different types of therapists and the role of nurse practitioners and psychology and our psychiatry colleagues and our DBPEDS colleagues. It's so important that we're regularly tracking follow-up. Even if the child is doing well, often families just want to hear from us that their child is doing okay and that, that they're on the right track. We want to make sure that we're supporting their decisions using evidence-based treatment guidelines. And there are a lot of family support groups out there that that will come in our a couple slides up. So whenever we're meeting with these families, we want to think about what they're going to initially need and what they're going to need down the line. And early on, we've already talked about this. We're going to get our full medical evaluations and our therapy evaluations. We've talked a lot about the educational needs of these children and what can be done through Head Start and through schools. And then families also need some guidance through applications for medical assistance, if the children qualify for supplemental Social Security, having a caseworker, having a social worker, having somebody who the families can use as a go-to is really going to help them out. When we think about their needs as they start growing older, they start having more social challenges. The families might come to you more saying about bullying. And Autism Speaks actually has a special needs anti-bullying toolkit that I highly recommend as something to review and share with families if it's something that you feel comfortable with. It's a great resource. We need to start having these open discussions about dating and sexuality, and make sure that as the child is getting older, this is a part of our ongoing conversations. And then we talked about the transition planning beginning at age 14 up to age 16, depending on where you live. But as we've already said, earlier is better. And then we want to talk about as they transition into adulthood. So first of all, are going to be meeting their health care needs and making sure that they have the appropriate health care. We're going to want to talk about family planning needs as they get older. When it comes to post-secondary education, there are a lot of colleges that have programs now that are really worthwhile for children with or young adults with autism. And there's also a lot of information on the Autism Speak website about transitioning to college, thinking about living independently, etc. And then also planning for housing and community living in our range of across the spectrum, the children who have a lot more needs and need a lot more supports versus those who are able to go out more independently. Talking about employment, where are they going to work? Is there offices of vocational rehabilitation involved? Financial planning is huge. A couple of the things that you want to make sure if they have an eligibility for SSI, that's going to help with their income. Their parents have to think about financial planning. They also need to think about the legal planning for these children. So a special needs will and trust is to make sure that the needs are being met legally for children. A couple of the possibilities are having a third-party trust that holds the money and the property for a young person who has special needs, either if they die early or to help with if their parents die young, and the other is a self-settled trust that is something that the individual with autism it handles their own money for them. Another piece is guardianship concerns for kids. A limited guardian makes decisions only in some areas, like medical care or financial, just some one specific area. A general guardian has broad control and decision-making capacity for the young person who has autism. And then finally, you can have a conservator who is only about managing finances. And families are going to start having all of these questions. And I know in pediatrics, we can see, we're seeing kids until age 21, depending on where your clinic is, et cetera. And a lot of these things are going to come up by then. I wanted to make mention of some of the family resources, and the first one I'm really going to talk about is the family toolkits from Autism Speaks. They have a 100-day toolkit that families can download for that new diagnosis and what do I do first. They hear you, but they're so overwhelmed, and being able to provide that as a resource is huge. Another thing is that parents can call directly to Autism Speaks and ask to talk to somebody from the autism support team. They are out there to connect families to tools and resources. There's a really nice toolkit about autism and medication that comes from Autism Speaks as well. Definitely worth taking a look at. And then very quickly to summarize, we know that this is complex. Diagnosis is complex. Treatment can be complex. We really want to identify early because that's going to improve our long-term outcomes. Their presentation and their needs are going to change as they get older. Their primary treatments will be behavioral and educational. Meds can definitely help. We want to use a chronic care approach and coordinate across many systems to help these children. It does take a village. And then make sure that the families are getting their ongoing support and you're out there for them. We do have some references that are listed for you, and we want to take some questions again in our last 5 minutes.
Yes, I don't know of any, but obviously access is a huge need, and access to services is difficult, and it's going to keep getting more and more difficult as more people get diagnosed. So different service models are going to have to be considered. So please work on it.
And thank you for being here.
Oh, yeah, no, I'm so excited. Do you know of, I think our biggest challenge right now is understanding kind of the legal aspects and how to structure partnerships between medical and non-medical professionals so you're not under a hospital umbrella and things like that. So I don't know if you know of any resources or even individual resources or consultants that.
Some hospitals have medical legal partnerships that you can consult with and that can help advocate for changes at a higher level. But I think it just varies so much. Do you have other?
Oh, and the other piece is really making sure that these children are part of a special care needs medical home, because that gives them this home base and at least this place for consideration for everybody. Everybody who comes to our clinic signs releases of information so that we are able to share information as well, because if they're not all within the same system, we still want to be talking.
Sorry, I just had a question about the psychopharmacology. You mentioned a 30% placebo response. I was wondering if you could tell me a little bit about, why that And is it the parents that see something? Or?
Well, I think that's true for anything. It's human nature. If you're trying something, you're hopeful, you're excited, you view things with more positive eyes. I think also whenever we're implementing a new treatment, people are more engaged. They may be more consistent with following other aspects of care, like the behavioral plan or things, and everything drifts over time. So I think there's some really interesting research in the behavioral literature about placebo responses that you might want to look into more, but it's not just related to autism or medications. It's related to a lot of different kinds of interventions.
Okay, we're really trying to run on time,
we've
so we're
got-
gonna.
Okay, we have 3 people who have questions, so shall they come up?
We
do you
have,
think?
yeah, we have a bunch more as well, so I think we should have people come on up if they have
Great.
other questions, and then we're gonna have lunch on our own, and then be back here at 1 o'clock for the afternoon session.
Thank you, everybody.